we're going to talk about randomized trials, and we'll get back to this paper in a few minutes, but they used a special design, a randomized design, to understand this issue better. And our objectives for today are to define what is a randomized trial, including its strengths and limitations. Why would we use a randomized trial? And then to talk about the uptake of HIV testing in community versus clinic programs. So this article was not the article for today, but it should be familiar. It's an article that we read 4 weeks ago, so you have to think way back to February, looking at retention associated with community-based accompaniment for antiretroviral therapy delivery in Rwanda. Does anyone remember what was the study design that they used to compare community-based treatments to clinic-based treatments? It was a cohort study, right? So with the cohort study, they had two groups. They had community-based treatment and they had clinic-based treatment. And they were trying to see the effect on these things on patient retention. So this was their exposed and their unexposed. Kayonza was the one getting the community-based treatment. And Gisini was the one that had the clinic-based treatment. So there was one cohort in Kayonza where they were getting the community-based accompaniment, and there was another cohort in Gisini that was getting the clinic-based treatment. And I asked you when we were looking at the cohort design, knowing what you know about Gisini and knowing what you know about Southern Kayonza, what could be different between the two cohorts besides the treatments in the community and the treatment in the clinic? And all of a sudden you started giving me this long list of things that are different between Kayonza and Gisini. What might other factors be different? So time from home to clinic might be different between Gisini and Kayonza, and it might affect the retention of the patient. What else could be different between those who live in Gisini and those who live in Kayonza? Socioeconomic, so wealth. Those in Gisini may have more money, and we know wealth is associated with better treatment outcomes. So the wealth is associated both with the intervention and with the outcome. What else could be different between Gisini and Kayonza? Nutrition. And again, if nutrition is different between Kayonza and Gisini, that affects the exposure. And we also know that nutrition can have an effect on the outcome. So the challenge with the cohort study that they used for this is that there are all these factors that could be different between Gisini and Kayonza that are also related to having retention. And they have to be very careful with these factors to make sure that they don't have what kind of bias? Confounding bias. So remember, one of our biggest challenges with cohort studies is if there are differences between the intervention or the exposed and the unexposed group, and those differences could affect the outcome, then you could have confounding bias that affects your ability to understand the results. If we do have confounding bias and we're able to measure those things, then we can do an adjustment in our analysis to control for confounding, and that's the adjusted odds ratio. But the challenge is sometimes there's things that are different that we don't even think to measure. So we may know that wealth is different and we measure wealth, but what if something like altitude matters and we don't measure altitude, or something like rain matters and we don't measure rain? So there's possible that these other outside factors could matter and we don't measure them, and so we cannot control for the confounding in our analysis. So this was a cohort study, and one of the biggest limitations or challenges is to make sure that we minimize this confounding bias. So that is where randomized trials come in, is we try to minimize the differences between those who get the exposure and those who don't by randomly choosing who gets the intervention and who does not. So we no longer say, hey, Kayonza gets the intervention, so is already getting the intervention, so we study them. And Gacini is already not, or getting the clinic-based care, so we study them. And those will be our cohorts. We don't let people choose where they get the intervention, or we don't let areas already have the intervention. Instead, in this case, controlling for confounders, we do that by randomly assigning. So let's say I want to do an intervention on vitamins. I could say, who wants to take the vitamins? And some people will say yes, and other people will say no, and compare them. Or I could say, you're all enrolled in the study, and when I see Nadine, I'm going to flip a coin. Heads, she gets the vitamin. I see Neza, I flip a coin. Heads, she gets a vitamin. I see Frederick, I flip a coin. Tails, he does not get a vitamin. And so the assignment to the groups is random. And we do this randomization to control for these outside factors to try and make sure they're not different between the groups. So here's an example. There's two groups. There's an intervention group and a control group. And an individual comes to the study, and I say, flip, flip, flip. C, you go to the control group. And so I put them in the control group. And another individual comes, and I say, C, you also go to the control group. A third individual comes, and I flip my coin, and it's I. They go to the intervention group. And the assignment between the intervention and control is done without any information. So you can see that there's starting to be some individuals who get the intervention and some individuals who do not. Another person comes, and I flip a coin, and I say, C, you go to the control group. And I'm randomly assigning to each of the groups. Now let's say I stop here. So here is my control group, and here's my intervention group. There's 10 people in each. Do these groups look the same? Let's say the outside confounders are the color. Do the colors look the same between the two groups? So there's some differences between the groups. And if you only have a few individuals in your groups, even if you randomize, you don't let people choose where they go, even if you randomize, there is the possibility that you will not achieve balance, that the groups will not look the same. So the solution around that is to keep randomizing. You keep adding people to each group. You want a large enough number so that the probability that there is balance is very high. So here, they may not be exactly the same, but they are starting to look more similar to each other. You've got about the same number of yellows, about the same number of blues. So you need to have a large enough number of individuals that you're randomizing to get the balance between the intervention and controls. And the reason that we do this is if they are approximately the same, then this will minimize confounding bias. This will minimize confounding bias. So we want to randomize individuals to the different groups. We want to randomize enough individuals to the different groups so that they look about the same. And we do this to minimize that confounding bias. And what you'll see is in all the papers that have randomized trials, that first table, the first table we'll look at today, we'll do a test to see, is there balance? Are the two groups similar enough that we think that there is no outside confounding? Now, another possibility is that you randomize in groups. So in the last case, a patient comes, I flip a coin, and I say you get treatment or control. In this case, I take entire areas and I flip a coin. And in this case, the entire area goes to the control group. So maybe an entire village or an entire health center. Here's a second health center, and I flip a coin, and that entire health center goes to intervention. So here I have 4 health centers that go to the control and 4 health centers that go to the intervention. Why do you think we might randomize in groups? What are the strengths of group randomization? So we do group randomization because a lot of time interventions happen on the group level. So community-based treatment, we treat everyone who comes to the health center using the same model of care. It's much easier to manage. If Jeanette had to change the way she treats mothers by every other mother, it would start to get complicated and difficult to follow. And then it helps minimize exposure bias through contamination. So for example, if some people get counseling for HIV treatment and other people don't, if we do it health center by health center, the people who get the counseling are all together, so they're contacting each other, and the people who don't get the counseling, they are not together, they're all together and they're contacting each other. There's no talk between them. But within a health center, if I say some people get counseling and some people don't get counseling, those people could talk to each other and start saying, well, in my counseling session I learned this, this, and this, and there would be exposure bias through contamination. 2 disadvantages is it is harder to achieve balance. So if I only have 8 health centers and some get treatment and some do not, or some get intervention and some are control, 4 are getting intervention, 4 are control, they're probably going to look more dissimilar. You can think about the 8 health centers in southern Kayonza. They all look very different. It would be difficult to have 4 that look the same, to have 2 groups of 4 that look similar to each other because the health centers are so different from each other. So it is very difficult when you randomize in groups to get that balance, and the analysis is much more difficult. Okay? So when you get to the statistical analysis of group trials, it is much more complicated than individual trials. So in terms of advantages of randomized trials, it is considered to be the gold standard by many. So ideally, every study I would do would be a randomized trial. And it's really because of minimizing that confounding bias to make sure that it's truly your intervention that's having that effect that you see. It tends to be more convincing. This is the gold standard argument because of minimizing confounding. And it's oftentimes done in a more controlled environment. So if you're doing a randomized trial and you're going through the process of randomization, you probably have very good data collectors and very good data collection tools and very good statisticians to analyze your data. You're doing things in a very controlled environment to make sure that your results are convincing. You can blind participants so that they do not modify how they behave or how they reply. Now in this study today, you cannot blind a participant to knowing if they got tested in the clinic or they got tested in the community. Right? There's no way to blind a participant where they do not know if they were tested at home or at the hospital. But in the study that you read for your homework, they are giving drugs to people. And to some people, they are giving treatment. And to other people, they're giving a pill. It looks just the same, and it's just sugar. It's what we call placebo. And in that case, they are blinded to know if they are getting a drug or if they are getting sugar. And so one of the advantages is you can blind participants in the hopes that you do not affect their behavior or how they reply. So that is minimizing measurement bias. And then finally, because of the controlled environments, we say that it has good internal validity. So we really are confident the results that they saw are attributable to their intervention. We think that there's little confounding bias. We hope that there's little measurement and bias, little exposure bias, little selection bias, so that we really believe the results that we see. There's good internal validity. So disadvantages, the expense you talked about. Ansil mentioned it can take a long time. Exposure bias, we got into this a little bit. So there might be contamination if people do not follow the intervention that they are assigned to. And then you need to make sure the study is ethical. So you need equipoise. So you need to know that there is not an advantage of one of the interventions over the other before you start randomizing individuals to the intervention. And then the one that we did not talk about just now is external validity. So because of the controlled environment, you may have limited external validity. Recreating that controlled environment is really tough. So I may show in a perfect hospital, in a very controlled setting in King Faisal Hospital, that a drug works. But I come here and I try it in Ringkwavu Hospital and I'm not seeing the same benefit. And maybe it's because we cannot identify the patients who need the drug. Or maybe there are stockouts. Or maybe I did not store it in good condition and the drugs don't work anymore. There could be all of these problems that when I try to apply it to my population, I don't see the same results. Okay? So because of the controlled environment, we may not be able to generalize what they found to other settings. And it depends on the study. I actually thought the study today had good external validity because it was not so controlled.